Hello everyone, my name is Laura Hart and I'm the Deputy Editor of the Lancet Neurology, and I'd like to welcome you to this Lancet webinar on autoimmune neuromuscular junction disorders. Before we begin, I'd just like to run through a few housekeeping points. So firstly, please feel free to type your questions to speakers using the chat function at any time during the webinar, and these will be read out at the end. You can find the Ask Question box, which looks like the picture on this screen. This is on your dashboard. You'll also be able to see a box with related content where the 3 series papers are. These were published in the Lancet Neurology on January the 19th. Please be aware that you can adjust the appearance of your own webinar dashboard by moving or minimizing any of the boxes to suit your preferences. And finally, just to say that the webinar is being recorded and a link to the on-demand version will be emailed to all registrants once the webinar has concluded. The series papers are also free to read on the lancet.com with registration, so please do read these at your own leisure if you haven't already done so. I will now run you through the agenda very briefly. So the aim of the webinar today is to provide further insights into the series of 3 papers on myasthenia gravis and Lambert-Eaton myasthenic syndrome. And I'm delighted to be joined today by 6 of the authors who will share their highlights from the series. So the webinar will begin with a brief introduction from Professor Jan Verschuuren, who is the series lead, and he will be co-chairing the webinar today. The first presentation from Maartje Huybers will be on the pathophysiology of autoimmune neuromuscular junction disorders. We will then hear from Rosen Leponts, who will be talking about immune dysregulation. And the next presentation will be on diagnosis, epidemiology, and future biomarkers, and will be delivered by Arne Punga. We will then listen to a talk on clinical aspects, outcome measures, and comorbidities from Emilia Everly. And the talk will be followed by a pre-recorded presentation on conventional therapies from Jackie Pallis, who unfortunately could not join us live today. And then the final presentation will be from Jan and will be on new or future treatment options. And then there'll be an opportunity for questions following that final presentation. So without further ado, I will hand over to my co-chair, Jan, who is head of the Department of Neurology and head of the Clinical Neuromuscular section at the Leiden University Medical Centre in the Netherlands. Thank you, Jan.
Thank you. I'm very pleased that today we can provide an introduction on the topics of these 3 papers. It was very nice to collaborate with Lancet Neurology in preparing these papers, and we hope that the information will be very useful for the clinicians and also for the researchers in this field. And yeah, I think I look forward to this presentation. I think we can start with the first speaker, Laura. Thank you.
Yes, so I'd like to welcome our first speaker. Maartje Huybers is an assistant professor in the Department of Neurology and the Department of Human Genetics at Leiden University Medical Centre in the Netherlands. Thank you, Maartje.
Good afternoon, everyone. It's really a great honor to, on behalf of our team, present the highlights of our review paper on the pathophysiology of neuromuscular junction autoimmune disorders. These are my disclosures. So the location where a motor neuron instructs a muscle fiber to contract is called the neuromuscular junction. And this area is highly specialized to ensure skeletal muscle activity, which is essential for walking, talking, for example, breathing. The neuromuscular junction is capped by a terminal Schwann cell. Let's see if it works. Yeah. It's capped by a terminal Schwann cell that provides trophic support and protection. And in 2008, a 4th cell type was identified at the neuromuscular junction, which is called the cranocyte, for which its role is still largely unknown. Neuromuscular transmission occurs when a depolarization reaches the motor nerve terminal. There, it activates the voltage-gated calcium channels, which stimulates the release of the neurotransmitter acetylcholine. And acetylcholine then diffuses through the synaptic cleft, where it reaches the postsynaptic muscle membrane and can bind to the acetylcholine receptors there. And upon binding of acetylcholine, these acetylcholine receptors open up their ion channels, and an ion flux occurs, which results in depolarization of the muscle fiber membrane. And if this reaches a threshold, an action potential is generated and runs along the muscle membrane towards the calcium storages that stimulate the release of calcium into the muscle fiber, which ultimately causes muscle contraction. So several aspects are really critical in this for neuromuscular junction functioning. And first of all, this is the alignment of presynaptic release of acetylcholine and reception of the signal by clustered acetylcholine receptors on the muscle membrane. And this is mediated by the agrin LP4 MuSK signaling cascade. Aside from that, the tertiary structure of the neuromuscular junction is really critical for its functioning. And we now know that autoantibodies directed against any of these essential proteins in the neuromuscular synapse can cause myasthenic syndromes. So autoimmunity at the neuromuscular synapse can be categorized in 3 subtypes. So the first subgroup is hallmarked by autoantibodies directed against postsynaptic components, and those are classified as myasthenia gravis. The second group of patients have autoantibodies against presynaptic components, and those are classified as Lambert-Eaton myasthenic syndrome, or in short, LAMS. And there's a third group of patients in whom we suspect there's an autoimmune response at the neuromuscular synapse, but in whom we do not know what the antigenic target is yet. And those patients are classified as seronegative myasthenia gravis or seronegative LAMS. So from a pathophysiological perspective, there are several interesting observations if you look at the different subtypes of myasthenia gravis and LAMS. So for example, when we look at the causative autoantibodies, there is a dominance in terms of antibody subclass. So for example, for acetylcholine receptor myasthenia gravis, this is the IG1 and 3 subclasses. And the same is true for patients with antibodies against LRP4 or patients with antibodies against presynaptic voltage-gated calcium channels, and thus with LAMS. However, for example, for MuSK myasthenia gravis, the autoantibodies are predominantly of the IG4 subclass, and this becomes relevant later on for the pathophysiology. There's also some other interesting observations. For example, the fact that there are strong HLA associations observed in these patient groups, and for example, that acetylcholine receptor myasthenia gravis patients and LAMS patients share this specific correlation with the DR3B8 haplotypes. And lastly and importantly, some of these patient subgroups are also characterized by the involvement of a tumor, for example, thymoma in acetylcholine receptor myasthenia gravis, or a small cell lung cancer in Lambert-Eaton myasthenic syndrome. Now, what do we know about the pathophysiology of these different subgroups of myasthenia gravis and Lambert-Eaton myasthenic syndrome? So when we look at acetylcholine receptor myasthenia gravis, it's important that these autoantibodies are of the immunologically active IG1 and IG3 subclass. And this means that once these autoantibodies bind to the acetylcholine receptor, they can activate complement and thereby cause complement-mediated damage. And this, by the way, has already been shown in very essential experiments in the 1980s and the 90s. What we've also seen is that these antibodies, because of their functional bivalency, so basically they have 2 arms that can interact with 2 different antigens, they can cross-link the acetylcholine receptors and internalize them. And thereby we lose these critical receptors for neurotransmission, and this also results in muscle weakness. And the third mechanism that these antibodies can cause myasthenia with is by blocking the binding of acetylcholine. And in recent years, some studies have shown that this might be a more important mechanism than that was previously thought. So when we look at MuSK myasthenia gravis, a lot of research has been done in the last decade on this, and it's a completely different story from acetylcholine receptor myasthenia gravis, because these autoantibodies are mainly of the immunologically inactive IG4 subclass, which means that complement doesn't play much of a role there, probably. But instead, it has been shown that these antibodies block the essential interaction of LRP4 and MuSK. Thereby, there's a loss of clustering of acetylcholine receptors, and that results in synaptic disintegration. It's also been shown that these antibodies can block the interaction between MuSK and CoQ, and CoQ is the anchor for acetylcholine esterase, which is a target for symptomatic treatment and may explain the reduced sensitivity of MuSK patients to this treatment. And lastly, Some patients also have IG1 and IG3 MuSK autoantibodies, and in myotube culture studies, it has been shown that these antibodies can have pathological effects, for example, by declustering acetylcholine receptors. In vivo this has not been reproduced, but it is interesting and requires further study. So over the last couple of years, there's also been several novel tools developed to study the pathophysiology of MuSK myasthenia gravis. And the important ones are the isolation of monoclonal antibodies from these patients. And these studies have revealed that, first of all, these identifying these B cells and antibody sequences has shown to be relatively hard, and these cells are relatively rare as well. They can be of different subclasses, so in spite of the fact that these autoantibodies are predominantly of the IG4 subclass, the autoantibodies that have been isolated from patients can be of different subclasses. And the ones that have been isolated thus far are directed against the N-terminal domains of the MuSK protein. They require maturation to become pathogenic. And which is also important is the fact that the pathogenicity of these autoantibodies can be clone dependent, but also valency dependent. So it matters whether these antibodies have either one or two arms binding the MuSK protein. Now, these are also very interesting tools to reproduce the disease in experimental animals. For Lambert-Eaton myasthenic syndrome, we also know that the autoantibodies are of the immunologically active IG1 and IG3 subclass, and it's been shown that there are reduced numbers of acetylcholine quanta released per nerve impulse in these experimental models, and this is likely related to the loss of voltage-gated calcium channels on the motor nerve terminal. But what the exact mechanism of disease is in this subgroup of autoimmune diseases still requires elucidation. And what's also important is to realize that in these patients often other autoantibodies exist against intracellular antigens, which may be related to the existence of a small cell lung cancer. Now, I also mentioned that there are also several other MG subtypes identified in the last couple of years, among which LRP4 myasthenia gravis and and Agrin myasthenia gravis. And it's assumed that these are also mediated mostly by IG1, so immunologically active autoantibodies. And for those subtypes of myasthenia gravis, still a lot can be discovered. What's also an important observation in both patients and animal models for these myasthenic diseases is the fact that there's large heterogeneity in muscle weakness, in muscle weakness patterns, so not every muscle is affected equally. And this may have to do with the way that these autoantibodies can access the specific muscles, the level and characteristics of the antigenic target, the safety factor, for example, the presence of complement inhibitory factors on these muscle membranes, and regeneration differences between different muscle groups. And what's also important to realize that these neuromuscular junctions are not really passive organs. They try to withstand the autoantibody attack. And they do so, for example, by upregulation of content, or, for example, there may be a role for Agrin, LRP4, and MuSK, which I think would be very interesting to look into in the future. So last but not least, several novel models have come about in recent years to study the pathophysiology of these autoimmune disorders. We already discussed the monoclonal antibodies that have been isolated from patients. But for example, single cell and single nucleus sequencing technologies are also important to better understand the immunological aspects of these autoimmune diseases. And next to this, several models have come about, both in vitro, and you can think about iPSC-based 3D NMJs or organoids, but also the different animal models, both passive and active, so passive transfer, active immunization models, that provide great tools for preclinical studies of MuSK myasthenia gravis, LRP4, and Agrin myasthenia gravis. And with that, I would like to give the floor back to Laura.
Thank you very much, Martia, for starting off our webinar. We'll now hear from Rosen Leponce, who is Director of Research at the National Centre for Scientific Research and Team Leader at the Research Centre of Myology of Sorbonne University at Le Petit-Salpêtrière Hospital in France. Thank you, Rosen.
Hi, hello everybody. So I'm very pleased to be here today for this special series of webinars. And I want to thank Margie for this nice introduction. So I will go straight to the topic of my talk. So I have no disclosure. And today I will speak about immune dysregulation in autoimmune neuromuscular junction disorders. But you will see that my talk will be mainly focused on myasthenia gravis patients with antibody against the acetylcholine receptor. This is because there is not so much studies that have been done so far on the other form of myasthenia gravis, and there are even less studies that have been done on Lambert-Eaton myasthenic syndrome patients. So what I could say is that the main feature in a patient with antibodies against the acetylcholine receptor is that the thymus is abnormal. This might explain why there are so many studies on this subtype of the disease. So what is happening in the thymus of the patient? So on the left side of the slide, I have described what is happening in early onset myasthenia gravis patient. And I would say that the thymus is behaving like a tertiary lymphoid organ. The thymus in this patient is characterized by neuroangiogenic processes. There is also the overexpression of numerous cytokines and chemokines that will favor the recruitment of peripheral cells, and mainly B cells. And this cell will lead to the development of ectopic germinal center within the thymus. And this will lead to the production of autoreactive T and B cells. What I want to focus on is that in the last year, it has been shown that this thymic environment, this inflammation within the thymus, favor the differentiation of a recently described type of T cells, the Th70 T cells, and I will speak later on about these cells. Now, let's speak about what is happening in the other category of myasthenia gravis patients, those that develop myasthenia gravis after the 50 years old, I would say. For this patient, myasthenia gravis is often associated with a thymoma. Thymomas are thymic epithelial cells tumors, and the risk of developing myasthenia gravis is depending about the subtype of thymoma. And the higher risk is associated mainly with the B2 subtype. And what is observed in the thymus of this patient is that there is an accumulation of immature thymocytes. There is an alteration of the epithelial network and a decrease of medullary areas. And this is associated with the loss of expression of a transcription factor called AIR. And this transcription factor is very important for the expression of what we call tissue-specific antigens that are necessary to educate T cells. So the absence of AIR might favor autoimmunity and the escape of autoreactive T cells. And what have been observed in patients with thymoma is that they can develop a lot of autoantibodies against tissue-specific antigen, but also against cytokines. And it is important to know that approximately 30% of patients with thymoma are at risk to develop myasthenia gravis. And to underline what are the recent findings on thymoma patients with myasthenia gravis, is that it has been observed that in the adjacent tissue of thymoma, there are changes that are quite similar to what is observed in the early onset form of the disease. We can observe the development of high endothelial venules, the recruitment of B cells due to the overexpression of the chemokine CXL13. There is also an increase in T follicular helper cells, and the development of fused germinal centers. So thymectomy is one of the treatments that is proposed to patients. It's mandatory for patients that have got a thymoma, and it is strongly encouraged, I would say, for early onset myasthenia gravis patients. For years, it was, I would say, empirically shown that it was beneficial. But recently, an international clinical trial has clearly proved that thymectomy is beneficial for patients with an early onset form of the disease. And as you can see here on this slide, this clinical trial as compare two groups of patients. One group with prednisone alone, and the other group with prednisone, but these patients were also thymectomized. And what has been observed is that after a while, the clinical score of patients that were thymectomized was improving much more as compared to the patients that were treated only with prednisone. And it was also shown that the daily dose of prednisone that was necessary for the patient was decreased for patients that was thymectomized. And these results have been observed after 3 years, and they have been confirmed even in patients after 5 years. So what is the hypothesis behind this beneficial effect of thymectomy? It's quite easy to understand that the removal of the thymus will get rid of the patient of the inflammatory site that sustains autoreactive reaction and the production of autoreactive cells. And to support this hypothesis, I want to mention this very recent study. It's a very nice study that has been done by Young and collaborators. And they have used the blood samples from the patients involved in this clinical trial. They use blood sample and thymic cells from patients before thymectomy and also after thymectomy for blood samples. And what they have observed, in fact, what they have done, they have analyzed the sequence of the B cell receptor on B cells, and they have observed that there were clonally related B cells within the thymus and the circulation of these patients. And they have demonstrated that these clones initially mature in the thymus. They can persist in the circulation after thymectomy, but usually they decline, and this decline is correlated with improvement of the patients. So this study was really nice. And I want to pursue this talk by speaking a little bit about another property or ability, capacity of B cells. We usually describe B cells as cells that are able to produce antibody and autoantibodies, but they have also the ability to be regulatory cells. During the process of differentiation, they can become what we call Breg cells. They've got immunosuppressive function by secreting diverse cytokines, and especially IL-10. And what has been observed here on the left side on the slide, on the right side, sorry, it has been observed in patients that got antibodies against the acetylcholine receptors that there is a decreased number of Breg cells, and this decrease is normalized in patients after thymectomy. It's what you can see on the very right side of the slide. And not only the number of cells is decreased in myasthenia gravis patients, but the functionality as well is altered. As you can see, B cells from MG patients lose their ability to produce IL-10 upon stimulation. So these observations have been made on patients with antibodies against the acetylcholine receptor, but it has also been observed that for patients with MuSK antibody, there is also a decrease in Breg cells. So now, what about T cell? What is happening in T cells? So on this slide, I have briefly summarized the last advances that have been done regarding T cells. And I have put in parallel what is happening in the thymus of the patient and in the periphery, and you will see that it's closely related. First, there are many studies that have been done on Th17 cells. These cells, they play a role in host defense, but if they are abnormally activated, they are also implicated in autoimmunity. And what has been observed is that the number of Th17 cells is increased in the thymus of myasthenia gravis patients, is what you can see on the left of the slide. And this increase in the number of Th17 cells is due to the release by thymic epithelial cells of a cytokine called IL-23. So in myasthenia gravis patients, there is an increased expression of this cytokine, and it will favor the differentiation of naive T cells into pathogenic Th17 cells. And what is observed in the thymus, it's also observed in periphery. As you can see on the graph below, there is an increase in Th17 cells in the periphery in AChR positive myasthenia gravis patients. There is no increase in seronegative, I would say complete seronegative myasthenia gravis patients. But there is also a nice study that has been shown recently that there is also an increase in Th17 cells in MuSK myasthenia gravis patients. So in the center of this slide, I have described what is happening for T follicular helper cells. So these cells are very important for the development of germinal center. And you can see that there is an increase of these cells in the thymus of myasthenia gravis patient, and it's quite easily to understand. But we have also an increase in periphery. And this decrease in periphery is what you can see at the bottom of the slide. This decrease is normalized in patients after thymectomy. So there is still a very interesting link between what is happening in the thymus and the periphery of patients. And at last, I want to speak a little bit about regulatory T cells. So these cells are very important to control the proliferation of effector T cells. And the number of these cells does not seem to be altered in patient, in myasthenia gravis patient, I would say, with antibodies against the acetylcholine receptor. But the function is really altered. It's what you can see here on this graph. The regulatory T cells from myasthenia gravis patients, when they are purified from the thymus of these patients, they are less capable to inhibit the proliferation of effector T cells. And this is also observed to a lesser degree in periphery. And what has been demonstrated is that this, I would say, this default in Treg cells is due to the education of these T cells within the thymus. It has been demonstrated that co-culturing normal Treg from an healthy donor with thymic epithelial cell from a myasthenia gravis patient will render this Treg less efficient. And this is due to the secretion of cytokine by thymic epithelial cell from myasthenia gravis patient. And one of them is a cytokine called TSLP. And what is interesting is to mention that even if there is not so much data on immune dysregulation for Lambert-Eaton myasthenic syndrome patient, there is a paper from 2008 that has shown that there might be a default as well in this patient for Treg cells. So here is my last slide with data, I would say. And this slide is just to illustrate that recently, thanks to new technology that allow to do multiparametric analysis, this technology are the mass cytometry or spectral cytometry. And this technology are very helpful to reveal subtle changes that we were not able to see sometimes with classical flow cytometry. And in this study, from Angel Finger and collaborator, they have investigated late onset myasthenia gravis patient with antibody against the acetylcholine receptor. And what they have observed for the first time is a decrease in CD4 T effector cells that express GM-CSF. So I'm sure that in the future, there will be more and more discovery using these new technologies. And my very last slide is just here to mention 3 points that I think might be the challenges for the years to come. The first one would be to investigate what is happening in Lambert-Eaton myasthenic syndrome, because there is hardly anything regarding immune dysregulations. My second point would be about the increased number of patients that develop autoimmunity upon immune checkpoint inhibitor therapies. And I think that it would be very interesting to compare this, I would say, induced autoimmunity compared to natural autoimmunity. And that might help to discover the etiological or the pathophysiological mechanism underlying autoimmunity. And to conclude, and I'm sure that Anna will speak about that just after me, in the recent years, there have been many studies on microRNA. And this study have used microRNA as biomarker to categorize the patient. But now, this microRNA, we know that they can modulate a biological process. And it would be very interesting in the years to come to analyze the impact of this microRNA, not just as biomarker, but as a modulator of the immune system. And I will end with this fact, and I want to thank you for your attention.
Thank you very much, Rosen. I will now welcome Anna Punga, who is Professor of Clinical Neurophysiology at Uppsala University in Sweden. Anna also works as a consultant physician and department head of Clinical Neurophysiology at Uppsala University Hospital. Thank you, Anna.
Thank you very much for this introduction, Laura. And on behalf of the co-authors of paper 2, I will present one of the topics there. These are my disclosures. So regarding the diagnostic evaluation scheme for MG and LEMS, in addition to the typical fatigable skeletal muscle weakness, there are particular tests that we want to do in order to secure the diagnosis. And these are mainly the antibody tests, electrophysiology, and chest imaging, as you see in these different panels. They're supposed to be very colorful. So in myasthenia gravis, antibodies against the acetylcholine receptor and MuSK and LRP4 are important for the diagnosis as well as the classification into serological subgroup, and Marta touched upon that. And most commonly, the radioimmunoassays are being employed, and more rarely, cell-based assays are used, mainly for research purposes. They may be more difficult to get hold of. And in LEMS, more than 85% of patients have antibodies against the presynaptic PQ-type voltage-gated calcium channels. In the middle, electrophysiology is displayed, and that has the role of ruling out other neurogenic or myopathic conditions with nerve conduction studies and EMG, and confirm disturbed neuromuscular transmission, either via increased decrement on low-frequency repetitive nerve stimulation or increased jitter and blockings at single-fiber EMG. And here, the facial muscle, especially the ones surrounding the eyes, orbicularis oculi, and frontalis muscles, are the most sensitive muscles. In LEMS, one can often notice low amplitudes of the compound motor action potentials at rest, and high-frequency stimulation may elicit an increment of the amplitudes of more than 60%. We also, of course, have the chest imaging techniques, and that is really to try to verify thymoma in MG patients, where it's present in about 10 to 20%, and small cell lung cancer, which is present in more than half of LEMS patients. And we also have the supportive tests that may add to the diagnostic if you can't do any of these other tests. And they include the IcePack test and the acetylcholinesterase inhibitor trial to assess improvement of primarily ptosis or other objective muscle weakness symptoms. Amelia Everly will go through the clinical picture more in detail. So patients with myasthenia gravis are typically divided into subgroups. It may be a little bit confusing, subtypes and subgroups. This refers to the patients, how we classify them in the clinic and in clinical trials. And they are classified according to antibody status here to the left. And that includes the predominant acetylcholine receptor antibody seropositive MG group. And that accounts for approximately 85% of all the patients. And less common antibody subgroups of MuSK and LRP4, or the seronegative group, which refer to not finding any of the above-mentioned antibodies. Then we have age of onset, and that is also referring back to what Rosen said with thymus pathology and hyperplasia. So we have the pediatric patient in the juvenile onset group that are below the age of 18. And then we have the early onset ranging from 19 to 50 years of age, the late onset above 50 years of age. And in the last year, a new group have emerged, and that's the very late onset group. And it's above the age of 65 years old. And this group is really being the most predominant that we see in several studies. Then we have the clinical phenotype, which may differ over time. And we distinguish the ocular form of MG, which is being characterized by having only extraocular muscle involvement, ptosis and diplopia, versus the generalized form with all types of muscle involvement outside of the ocular area. And finally, we have the thymoma-associated MG. And this is an exciting part of research which have emerged through the past years of epidemiological studies. So the number of epidemiological studies have greatly increased around the world. And as you see here, the different colors of the little dots mark the newly made studies on epidemiology, and those are the red dots. So thanks to this, we now have prevalence and incidence rates in countries where the disease where it was previously unknown, these prevalence and incidence numbers. So it has really emerged, and especially nationwide studies on epidemiology during the last 2 decades. And the spread around the world, whereas the predominant AChR antibody subgroup is more uniformly spread around the world, we do have a more distinctive spread of the MuSK antibody, MG, which is more common in people of African and African American descent than in white people. And the prevalence follows really a north-south latitude gradient, with more cases closer to the equator. And this is believed to result from genetic or unknown environmental factors, but it requires more studies. And the frequency of LRP4 antibodies in seronegative MG varies from huge numbers, from 1% to 54%. And this large variation is probably explained by geographical differences, with a lower prevalence in Asian countries. Yeah, and an increasing number of MG cases are being reported in adults at all ages of onset, actually, with an annual incidence of 10 to 29 cases per million a year, and a prevalence ranging from 100 to 350 cases per million a year. And recent trends suggest that the prevalence is increasing, especially in older people. And this is probably largely as a result of an aging population, but also, of course, influenced by the better diagnostic measures. And I think that we will hear in the end about the more efficient therapeutic strategies. And more females develop early onset MG and MuSK MG, whereas more males are seen in the late onset age span. And for Lambert-Eaton myasthenic syndrome is, of course, much rarer than MG, with an incidence of approximately 0.2 to 0.4 cases per 1 million people a year, and a prevalence of approximately 2.5 per 1 million people. But there is also underestimates, since there is initially common with misdiagnosis, and this is important to keep in mind. The more we know about this, the more we are able to diagnose this disease. And excitingly, as Rosa mentioned, with outcome measures and biomarkers, this is something that we really need. So available outcome measures in MG include serial antibody titers of AChR and especially MuSK antibodies. However, these typically do not predict the disease course. MuSK antibodies are believed to be somewhat more useful than AChR antibody levels to follow over time. Abnormal jitter with single fiber EMG in the orbicularis oculi muscle does have predictive value for the therapeutic response, but this is not available in all centers, so it may be difficult to do it practically. Screening for thymoma is mandatory, and we also have the access of quantitative MRI of the orbits in order to help differentiating active ophthalmoplegia in MG and Graves' orbitopathy. With the LEMS screening protocol for small cell lung cancer, this is detected within 12 months in at least 95% of patients, which is really great. So with radiology, one can really diagnose these patients with small cell lung cancer. And additionally, the presence of specific antibodies directed against SOX2, N-type VGCCs, or GABA-B antibodies is very highly sensitive and specific for the detection of small cell lung cancer-associated LEMS. However, we still have the challenge of the fluctuating disease course, especially in MG. So there is a great need for objective biomarkers. So there's a lot of research focus going into this at the moment and in the coming years. So circulating microRNAs, as Rosen mentioned, have been suggested for this purpose, since they are easy to measure in body fluids, especially serum. And the microRNA 155P and microRNA 215P are higher in AChR antibody NG and decreases with immunosuppression and clinical improvement. And it's very interesting that these also regulate the development, the differentiation of T cells. Another microRNA, miR30E5P, is higher in late onset NG patients with ocular onset who later generalized, and it has a predictive potential that will be looked more into in the nearest future. Also, just to mention HLA genes, and we know that there is an association with early onset MG and LEMS with HLA DR3 and HLA B8. And with that, I leave over again to Laura and then to Amelia. Thank you.
Thank you very much, Anna. I'd now like to introduce Amelia Everly, who is an Associate Professor of Neurology in the Neuroscience Department at the Catholic University in Rome and leads the myasthenia gravis unit in the University Hospital Policlinico Gemelli in Rome, Italy. Thank you, Amelia.
Thank you, Laura, for the introduction, and thanks to all my colleagues for this wonderful collaborative work. These are my disclosures. And in most patients with myasthenia gravis or Lambert-Eaton myasthenic syndrome, in spite of the variability of symptom extension and severity, the pattern of muscle weakness is quite typical because some muscles are involved more commonly than others. In myasthenia gravis, we have ocular and cranial muscles that are the most commonly involved, and a substantial proportion of patients have weakness of neck, bulbar, and in limbs of proximal muscles. In Lambert-Eaton syndrome, weakness tends to spread in a caudal to cranial direction, and most patients complain since the presentation of lower limb proximal weakness. But some patients may have an atypical pattern because of focal weakness, and this can complicate diagnosis. A limb-guardial myasthenia is more often a congenital disease. When it occurs in myasthenia gravis, it affects mostly young people and generally in association with AChR antibodies. Focal weakness in limbs preferentially involves extensor muscles. A presentation with a dropping head is very uncommon, but it can be found in association with masked antibodies and AChR positive late onset myasthenia. A presentation with a focal barbal pattern is very uncommon, but can be found in association with masked antibodies. And diagnostic clues in these cases are the bilateral involvement, fatigability, no or very mild muscle atrophy, but it's also very important to search for mild unnoticed weakness and of course to test for disease-specific antibodies. And most patients with myasthenia gravis and LEMS present with ocular symptoms that have specific characteristics that are helpful in the differential diagnosis. Most patients have both ptosis and ophthalmoparesis with diplopia, and ocular muscles are typically involved in a symmetrical way. On the other hand, in congenital disease, ptosis is always present, diplopia can be absent, and asymmetry is very rare. In orbital myositis and thyroid orthopathy, ptosis is very uncommon. Although most patients present with purely ocular myasthenia, most progress to generalized disease, but the risk of generalization is much lower in children with prepubertal onset, irrespective of ethnicity, while it is increased in SHR positive than in seronegative patients. And differently from myasthenia gravis, a purely ocular presentation is very rare in LAMS. And in patients with generalized disease, respiratory failure caused by myasthenia gravis represents the most serious complication. It is still the leading cause of mortality in patients needing hospitalization. We know that crises have well-defined triggering factors. First of all, respiratory infections, although in a proportion of patients no trigger can be detected. The crisis rate is different among patient subgroups, and crises are rarer in the Lambert-Eaton syndrome, but can occur, particularly in patients with paraneoplastic disease, who often have a more progressive course. And the course of myasthenia gravis is assessed with the help of disease-specific numeric scales that are aimed at quantifying muscle weakness and at detecting changes in disease severity over time. These scales are multi-items. Most of them include both patient-reported and physician-rated items, but recent scales include more patients-reported outcome measure according to FDA recommendation. Quality of life measures provide a patient-perceived tolerability of MG symptoms, and more recently, the steroid-sparing effect of a certain treatment that has been used as outcome measure in trials. And as for trigger, respiratory infections are the most frequently reported preceding event of the onset or exacerbations of myasthenia gravis, but more recently the disease, and much more rarely LAMS, has been reported as rare adverse events of treatment with immune checkpoint inhibitors. In these patients, myasthenia gravis is often associated with myositis and myocarditis, and particularly the latter can contribute to mortality. It is well known that autoimmunity is frequent in myasthenia gravis, particularly in early onset SHR-positive patients. On the other hand, medical comorbidities, as expected, are linked to patients' age. Of course, complicated treatment are associated with a higher rate of hospitalization and contribute to mortality. In patients with non-tumor LAMS, survival is similar to the general population. Of course, is shorter in patients with small cell lung carcinoma, but is still more prolonged than in subjects with small cell lung carcinoma without the neurological disease. So I'm finished. Thank you, Laura, and we'll go to the next presentation.
Thank you very much, Amelia. So we will now play the pre-recorded presentation from Jackie Pallis, who is a consultant neurologist in Oxford and professor in the Nuffield Department of Clinical Neurosciences at Oxford University in the UK.
I'm going to talk about the conventional treatments of myasthenia gravis, and I am Jackie Pallis from Oxford. Here are my disclosures. So pyridostigmine is the main symptomatic treatment, and it's initially used in most patients. It works within 30 to 60 minutes. And you don't need to wait many months to know whether it's working adequately. And indeed, under treatment, I'm going to talk about the conventional treatments of myasthenia gravis, and I am Jackie Pallis from Oxford. Here are my disclosures. So pyridostigmine is the main symptomatic treatment, and it's initially used in most patients. It works within 30 to 60 minutes. And you don't need to wait many months to know whether it's working adequately. And indeed, undertreatment is an issue. It can prolong disability unnecessarily. It's unclear, but there is some suggestion that it may increase the risk of resistant weakness, particularly in the ocular muscles, and may increase the risk of generalization if patients are left untreated unnecessarily. 3,4-DAP is licensed for use in Lambert-Eaton myasthenic syndrome. Salbutamol and ephedrine can be used orally, undergoing clinical trial in myasthenia gravis, and there's good theoretical reason why it may work in myasthenia gravis. It has been used for many years in congenital myasthenia. IVIG and plasma exchange are short-term immune therapies. They're used in a number of scenarios for temporary rescue in crises or when patients are very poorly controlled. They can be used in preparing or optimizing patients for surgery. In some instances where people are waiting for the delayed effects of thymectomy, it may be used temporarily as immune suppressant sparers where people are unkeen on using these. And occasionally some patients who are resistant may use these treatments long term. The improvement is usually seen at around 2 weeks and can last for around 4 to 8 weeks, and studies suggest that these treatments are comparable. The usual dose of IVIG is 2 grams per kilogram, usually given over 2 to 5 days. Can be used subcutaneously if it's used long term, and patients can self-administer this at home. And actually the dose can be reduced down to 1 gram per kilogram sometimes. Plasma exchange is usually given as a 5-day course, often on alternate days. So the long-term immune therapies tend to be given when pyridostigmine is insufficient, when patients aren't in remission. Occasionally, patients prefer to wait while the effects of thymectomy is awaited, which can take up to a year. But usually, immune suppressant kicks in fairly early on when pyridostigmine isn't working, and corticosteroids is the first line in most patients if there aren't contraindications. Usually use it at high dose to obtain remission, but often the dose is gradually increased to prevent worsening, unless they're in crisis, when you would then go in with a high dose. Lower dose is often possible in patients with ocular disease. Once remission is obtained, you then withdraw pyridostigmine first and then slowly reduce prednisolone to a maintenance dose of around 10 to 15 milligrams equivalent daily. There are a number of corticosteroid sparing agents which can be used add-on or alone, and they're shown here. So there was a thymectomy study a number of years ago in acetylcholine receptor antibody-positive myasthenics in early onset disease, that's within 5 years of onset. In those with age of onset less than 65, had to have generalized disease and non-thymoma patients. And both primary outcomes showed a significant effect. On the left, you've got the QMG score, which is a severity score. On the right, prednisolone dosage. In red, it's those that had thymectomy with prednisolone. In blue, just prednisolone alone. You can see that the severity score was lower in those with thymectomy, as was the prednisolone dose they needed. I've outlined here some of the other important secondary outcomes. Azathioprine dosage in the thymectomy group, which is on the right, it's only 17% versus 48% in those that didn't have thymectomy. IVIG usage, 17% versus 40%. Minimal manifestation status was much higher, high 60s versus 37 to 47% in those that didn't have thymectomy, and hospitalizations much lower, 9%, was much higher in those that didn't have thymectomy. Outlined here, just that there was a significant effect in those that were under 40 years disease onset compared to those that were over 40 years. And in the 2-year extension, there was again a significant effect in both outcomes. So in practice, we do thymectomy in those that are acetylcholine receptor antibody positive, where the thymus is implicated. IVIG and plasma exchange has been shown to be only useful in those with moderate to severe weakness. One study suggested IVIG had a better outcome, particularly in the intubation period was shorter in those with IVIG, although they weren't completely matched for their disease duration. There's expert consensus now that we do VAT surgery. It's much less invasive than the transsternal approach that was used in the thymectomy study. There are some differences in everyday life now. Most of us would extend what was used in the clinical trial. Patients with ocular myasthenia, if they're resistant or wish to avoid immunosuppressant, many of us would also use thymectomy in those. Older children, we would use it in patients beyond 5 years from onset, and antibody-negative patients who don't have MuSK antibodies, to remember that many of these will have antibodies to clustered AChR. Special considerations of the elderly. So if you look at some of the data out there, although they have more life-threatening events at onset, they actually tend to require fewer drugs, and they are less frequently drug refractory. So they often have milder disease later on. Considering pregnancy, well, corticosteroids and azathioprines are the treatment of choice, and tacrolimus and cyclosporine are probably safe from data in other diseases. There's little transfer of pyridostigmine, corticosteroids and azathioprine in breast milk. The other treatments are contraindicated in pregnancy and breastfeeding. And in children, to remember, there are more antibody-negative cases in children, and the differential, therefore, is genetic myasthenia. There's the potential for amblyopia in children with ophthalmoplegia, and therefore they need to be under an ophthalmologist. There are immune suppressant considerations in children, vaccinations, especially varicella. A lot of them have not had chickenpox. Growth failure and weight gain on corticosteroids need to be considered. They are more likely to achieve remission, especially in certain subgroups. But prolonged undertreatment has its own problems. Social isolation can lead to chronic illness behavior in children. And not to forget that children have childbearing potential post-pubescence.
I'd like to thank Jackie for taking the time to send us her presentation. And now for the final presentation, I'd like to hand you back over to Jan Verschuuren to talk about new treatment options. Thank you, Jan.
Thank you. Yes, I'd like to update you on the new treatment options for the autoimmune neuromuscular junction disorders. My disclosures are on some grants and consultancies and convention on the patent application. As the previous speakers have made clear, there is a lot of knowledge about the whole process within the immune system and in the thymus that leads to these pathogenic antibodies that in turn bind to these transmembrane proteins, many transmembrane proteins, at the neuromuscular synapse, which then induce the weakness. And because we know so much, we can also think about targeted therapies. And so the first group of therapies could strengthen the synapse muscle. You know, pyridostigmine, I think, is the most well-known example, increasing the function of the neuromuscular junction. We have ability to remove antibodies, as just was told by Jackie Pellis, intravenous immunoglobulin or plasma exchange. And we have means of inhibiting the antibody production by prednisolone and other steroid-sparing agents. And of course, the holy grail would be to have tools to repair tolerance, to selectively dismantle this antibody response against, for example, the acetylcholine receptor. But that is not yet present, so we'll focus on the other three possibilities. If we look over the last years, even the last 50 years, you see here circles displaying a study, a clinical study in patients with the different classes of drugs. Like at the bottom, the symptomatic drugs or corticosteroid treatments, steroid-sparing agents, and of course, a thyroidectomy, which already has been discussed. I would like to focus on the newer drugs because there is the most knowledge about clinical trials and most extensive publications, while there are also what they call newest drugs, which still are in the earlier phase of development, although they are applied in patients with myasthenia gravis, but not in largely randomized trials. As you can see, in the last 10 years, especially, there has been an increase in studies in autoimmune myasthenia, and the filled circles represent the significant randomized trials, which still are in a minority, but I must say also some of the more recent trials are still going on. So if we look at these new treatment strategies, first we have a class of inhibition of antibody production. And there are a lot of molecules known within the immune system for which now monoclonals are developed to selectively target these molecules and then to dampen the immune response. Secondly, there is this class of complement inhibition because, as you have heard, especially as the acetylcholine receptor myasthenia depends on complement, a secondary step in the pathogenesis, which probably plays an important role in this disease, and several companies are working on agents to inhibit complement activation. And thirdly, there is a new class of drugs, FcRn blockers, and several companies are working on these drugs which remove the antibodies from the serum. So first, let's look at anti-CD20 as an example of this interference with the immune function. I mean, rituximab, I think, has been the most well-studied drug so far in this category. And this drug kills pre-B cells, so it directly aims to inhibit the B cells in the production of antibodies. Here you see an overview of a review that summarizes lots of clinical studies, mostly case histories or small cohort studies. And as you can see, all of the results of this study are on the right of this red line, indicating that all these studies favor the use of rituximab over other kind of treatments. Interestingly, it seems to work for acetylcholine receptor antibodies, which are IgG1-mediated disease, as you have learned, and the MuSK, which are more IgG4. And seems to apply for all diseases, even for patients without antibodies. However, we think the consensus in the community is that anti-CD20 therapies have a better effect in the MuSK form of the disease than in the acetylcholine receptor myasthenia gravis. And this seems to be confirmed by the very recent results of the BEAT NMG study, which tested rituximab in a randomized fashion in a group of acetylcholine receptor positive patients with generalized disease. As you can appreciate from the two lines, the red line using rituximab, the blue line, the placebo group, with a follow-up over a year. And the aim was to reduce steroid reduction by at least 30%. And of course, see a significant difference. With the lines overlap, there's no significant reduction was found. We have to be reminded that it was maybe a relatively mild to moderate group, as also indicated by the authors, and maybe that has played a role in the negative effect. And it also stresses again how effective steroid treatment of myasthenia gravis still is. The other group is the complement inhibition, and in fact, eculizumab is of course a drug which already has obtained market authorization in a large part of the world, and it has been tested in a trial which had outcome measures, had 4 different scales of myasthenia. The ADL was the main outcome. It did not reach significance, although you can see that the trend in all 4 outcome measures was clearly in favor of eculizumab, which is the blue line. The lower the score in these measurements, the better the outcome in the myasthenia. So it was supported that all 4 pointed in the same direction, and based on these and other results, it's obtained market authorization for use in patients with generalized myasthenia gravis. The third group is a new group, is a very interesting new mechanism. It is blocking the FcRn receptor, and as you see, there are several drugs in development for this purpose. How does this work? Well, normally our IgG, as you see here, is taken up by the endothelial cell, indicated in blue in our vasculature. It is transported to a vesicle in which the pH is low, and in a low pH, as the antibody releases this bound protein. This protein then is transferred to the lysosomal department here and degraded. The clean washed IgG is then returned to the circulation. However, to be able to return to the circulation, it has to bind to a neonatal Fc receptor, the FcRn receptor. And the drug is blocking this receptor, so it's taking the seat of the IgGs. And therefore, the IgG is also transferred to the lysosomal compartment and broken down. So it's in fact using a physiological mechanism to break down the IgG of the patients. Here you see a study in healthy volunteers. If you give a placebo, the IgG level do not change. But if you give efgartigimod as an example of this class of new drugs, at different doses and different colors, you can see a steep decrease in the IgG up to 20-30% of normal within a time span of 2 to 3 weeks, which reminds us, of course, at treatment line like plasmapheresis of IVIG, which have similar effects. If you put all these treatments together, you can see here all the different options that have been discussed. And in yellow, I added the new drugs, so the complement inhibition or FcRn inhibition. This has a quite quick mode of onset, those newer drugs, so within a week. And the other drugs, which work more like an immune interference at the B and T cell level, they have normally a slower onset of a clinical effect after starting these drugs. As indicated here by the timeline on the x-axis. In the paper, we included a flow diagram which to assist you in making clinical decisions in the use of several classes of drugs, and we hope that that is helpful in looking and personalizing the treatment of the individual patients with myasthenia gravis or with Lambert-Eaton myasthenic syndrome. So in conclusion, we see multiple symptomatic and immunosuppressive drugs that already are available, and we think that it's safe to say that the majority of patients can be treated with conventional drugs. However, there is a remaining group of, say, about 10% which have more refractory disease in which we have need of newer or other drugs to treat those patients. And these new drugs with a new mode of action, like this complement inhibition, FcRn blocking, or interference with the immune pathways are promising, and they offer exciting possibilities for the treatment of myasthenia LEMS. But I have to say, in several countries, high cost of these new drugs are prohibitive for wide use. That's certainly a point for improvement. Thank you for your attention, and I give the word back to Laura.
Thank you very much, Jan, and thank you to all the speakers today for some excellent presentations. We've run a little bit over, but I think there's time for some Q&A. So please do type in the question box if anyone's got any questions, and we'll do our best to address them. So I'll pass back to Jan to take the first question.
Yeah, thank you. I see already a question. It's asking how we can differentiate seronegative myasthenia from late onset congenital myasthenic syndrome with the typical MG features, such as fast channel, for example. So the differentiation means seronegative and a late onset congenital. Maybe I can ask Amalia Evely to answer this question.
Okay. I must say that it's not at all easy to differentiate seronegative myasthenia gravis from a congenital disease that presents in late infancy or adolescence. I must say that the seronegative myasthenia should be diagnosed after exclusion of other conditions that may mimic myasthenia gravis. But with seronegative myasthenia, the differentiation is even more difficult because the response to cholinesterase inhibitors and EMG studies, do not differentiate between these two groups of diseases. So I should say that if family history is negative, and if the symptoms do not have many fluctuations that have a steady course or a progressive course without fluctuations, a congenital disease is possible, is even more than possible. Actually, fast channel syndrome is very severe, so we must take action with these patients. You must treat them. But in other conditions, when the anticholinesterase inhibitors are more or less effective, you can take your time, and if you suspect a congenital disease, you can perform genetic studies to, reach the correct diagnosis. So it depends on the disease severity, and also the clinical phenotype of the single patients must be very carefully considered.
Thank you. I see another question, Erik Stalberg. He's asking, I think very interesting, what is the mechanism for remission if we treat patients? I think it's indeed an interesting observation that, of course, we often start with high-dose immune suppression, and then after the patient gets into remission, we're able to lower the dose of remission while still the clinical symptoms remain stable or the patient remains in remission. So I think first, suppression of the immune system and decreasing of antibody attack is one side, and the other side is, I think, recovery of the neuromuscular synapse, and it's clearly a very active process there, which is happening. And then if the antibodies are low for some time and the synapses have recovered, then the balance is, I think, in favor, you can say, of the target organ for some time, even if antibodies might come up a little bit, or if you decrease the medication. That's, I don't know if any of the other presenters want to add something have other ideas about the stable remission after, for example, decreasing the medication. Maybe Anna or Emilia add something to that. Otherwise, maybe we go to the next question. The next question is, what has changed with the COVID-19 infection in prognosis?
Yes. Sorry. We must, first of all, we must distinguish between the situation between vaccination and after vaccination. Before vaccination, myasthenia gravis suffered from a higher mortality rate when infected with COVID. Now mortality is much reduced, and I think also for these fragile patients, the situation is much less dangerous than before. And in the before vaccination, I think that there was a great concern for myasthenia gravis patients. Otherwise, treatment, immunosuppressive treatment, was always well tolerated, did not worsen the COVID-19. In the literature, there are conflicting data about the possible role of rituximab in worsening COVID-19, but in some other papers, this is denied. The problem is to start new therapies, particularly biologics, during COVID-19. This depends on the disease severity. If you have to treat the severe myasthenia gravis or if you have to do maintenance treatment. That depends on the patient.
Thank you. There's a question of Florence Guibert. Are the anti-FcRn treatments possible to be used for long-term treatment? I think, yeah, that's an open question because the longest follow-up from the trial, I think, is now about 2 years. And it seems to be tolerated well if given intermittently, not constant infusions. So I think time has to learn a bit. Of course, we have to be careful with patients if they get too low in IgG for a very long time, you can imagine that they are more prone for infections, but there are no long-term data, not longer than, I think, 2 years or so. The question from Ivan Kmezik is, what is your experience on IL-6 inhibitors and, for example, tocilizumab? Well, so far there are still some trials going on for these categories of drugs. Personally, I don't have a wide experience with that, so I could not say if that would be very beneficial or would be a large advantage. I don't know if the other speakers had experience with this class of drugs already more extensively. I think it mostly small cohorts and case report at this moment. And another question, when the available treatments, is there still an unmet medical need in MG, except from a cost perspective? I think there is still a group, what I said, estimated as 5 or 10% of patients with severe refractory myasthenia, which sometimes are on chronic plasmapheresis or chronic IVIG. And that would be, I think, a group which could profit from some newer drugs. And maybe the opinion of the other speakers of Anna or Amelia. I realize that we have a lot of clinical questions here.
Yeah.
Do you agree with this?
Yes, of course, there are still unmet medical need in MG patients because the new available treatment are not available for all patients. Some patients are outside the indication for the use of treatment. But I think that, the situation, the therapeutic options are much increased in myasthenia gravis, and this unmet need concern, a smaller patient population than before.
Well, thank you. Then we have a question from Sabine Lenton. Efgartigimod has been licensed for antibody-positive patients only. Would there be a place for this type of treatment in seronegative patients at all? Well, in the trials there were some antibody-negative patients included. I think they were too small to have significant effect to do any conclusion on that. But of course, if the understanding is that the seronegative have effect a very low titer and maybe in cell-based assays these antibody titers could be detected, then theoretically, of course, these patients would also profit from this treatment. And you need the assumption that there is a pathogenic antibody circulating. That is, of course, a target for this therapy. And then at the question from Erwin Skeet, it was said that drugs are expensive. What mechanisms are in place so that patients have access to these drugs? Well, help us, I would say. It's in many countries, in Europe, of course, every country has its own rules in dealing with prices of drugs. So it's a difficult topic, and we, of course, only can support any mechanism to keep it low, but it's often the political and otherwise health regulations which make these things difficult. Maybe Amelia or Anna can add something from the other countries.
Yes, I think it's always the same problem. The price is very high, and of course there is some great concern about this problem. I don't know what to do. I don't know what is going on at the moment to lower the price of these drugs. But I think that regulatory agencies should be, deal with this problem, taking into account that we are dealing with a rare disease, that life-threatening disease, and of course, modern treatment must be offered to patients.
Okay. I see that we came to the end of the list of questions. Well, thank you for this active participation, I would say. And I would like to give the word back to Laura then.
Yes, thank you very much. We have actually gone over time. So that was just the right number of questions. So thank you again for the speakers for their very interesting presentations. And thank you to the listeners for taking part in this webinar. I hope you enjoyed it. And please do visit thelancet.com to read the 3 series papers. But from there, I think, well, it's time to end. Thank you very much, everyone. Bye.
Thank you.